there. What's your team? Introduce your team. I think this is UTH2.
This is me at our clinic. We've had people who joined us from outside the clinic. Can you hear me?
You're a little bit far. I think you're far away from the microphone. We can't hear you.
We are sitting in from Nangongwe clinic. We have some other people who joined us from outside the clinic as well.
Okay, welcome, Nangongwe, welcome. And we'll move on to Matero.
Clinics around. Thank you.
Move on to Matero. Thank you, Nangongwe. Matero, can you please introduce yourself?
Thank you very much. Matero Level 1 Hospital, Tatamba Chiwango, the team for Matero in.
Yeah, we are having a little bit of some issues here. I think we have a bit of some issues. So we have been joined by a number of people. We also have individuals that have joined themselves. And for the sake of time, we will not ask you to introduce yourselves. We have people joining us from the US. We have individuals joining us from within. And we'll proceed on with our session this afternoon. So for this afternoon, our session, we are talking about screening and prevention packages. And we have Dr. Mpeta that will be taking us through the presentation. We are not having a case presentation. We will have some case studies within the presentation. So we'll proceed with our presentation for today. I'll ask Dr. Mpeta to proceed.
Good afternoon, everyone. And as it has been announced, we are talking about screening and prevention packages in HIV-infected persons, and particularly we'll be talking about cotrimoxazole, TB, IPT, and screening for STIs. I should mention that I've got no financial disclosures, and the objectives for today are actually these three: to describe the overview of screening and prevention of OIs, then describe the algorithm for selected preventive therapies, that is cotrimoxazole, isoniazid preventive therapy, and for STIs. And then the third is to describe the tools used in screening and documentation of these preventive strategies. So an overview of screening and prevention of OIs. So OIs are the commonest cause of morbidity and mortality in people living with HIV infection. The commonest preventable OIs are cryptococcal infections, tuberculosis, PCP, which is pneumocystic girovenchi pneumonia, and STIs. So the prevention of death in HIV is a three-part strategy, which also fits in with the 90-90-90 approach. So the first one, of course, we know, which is early diagnosis of HIV and determination of the CD4 count, which accounts for the first 90, and then the second 90, which is early initiation of antiretroviral treatments. And then the third, which has to do with suppression, also has to do with the prevention of opportunistic infections and morbidity and mortality. So basically involves the screening of screening and prevention of selected OIs. So let's see how we are going to do with the 4 questions. Move on.
an IT issue here, so we'll be resuming soon. And just maybe to go through a recap of what we looked at last week. Last week we were looking at diagnosing and treating children with TB. And I think we had some interesting discussions last week, and this is a build on. And I just want to say that we are back. I think we have our presentation up there. So probably we can proceed with our today's session. We're going to have some polling questions, and we have our first question there. So I'd like to encourage you out there, all our participants from the spokes. The question is up, and please read the question and respond. We have a multiple choice question there. Would like to read it?
So I think I can see someone has already voted. It's concerning cotrimoxazole. A is recommended for HIV TB co-infected children, regardless of the clinical stage of infection. And then B can be stopped when a child is more than 2 years old and has CD4 greater than 25%. C should be given at birth in all HIV exposed infants. So we've got 3 who have voted so far. Okay, so I should mention that I think the poll question which was projected was from the previous presentation. Anyway, we have gone ahead and answered, but we shall talk about what we intended to highlight today. So the first screening and prevention that we're going to talk about has to do with cotrimoxazole preventive therapy, which is abbreviated as CPT. So cotrimoxazole preventive therapy prevents PCP, toxoplasmosis, malaria, and isosporiasis. It's also said to prolong survival in HIV-infected individuals, and then HIV-infected pregnant women should not be given Fansidar for prevention of malaria while they are on cotrimoxazole preventive therapy. So if we look at the criteria for initiating and discontinuing CPT in children, of course, as we know that children are classified in age bundles and also by different exposures. So if we look at children who are under the age of 5, the first one that we look at as HIV-exposed infants. So in all HIV-exposed infants, cotrimoxazole preventive therapy is indicated at 6 weeks, at the age of 6 weeks, or first contact afterwards. So if a child is 6 weeks or more, any day that they come to the health facility, please, you have to start cotrimoxazole preventive therapy. And then you can only stop if the child is confirmed HIV uninfected or HIV negative after full breastfeeding cessation. So that is if you follow the testing algorithm for infants. So that is after full breastfeeding cessation, then that's when you can stop. And if it's confirmed that the child is HIV uninfected. For HIV infected who are less than 24 months old, you start the cotrimoxazole regardless of the clinical staging, WHO clinical staging. And then indication for stopping is when CD4 is greater than 25%, or if the child does well on treatment and remains in WHO clinical staging, stage 1. For HIV-infected children who are above 24 months, the indication for starting is WHO clinical staging 2 or greater, that is 2, 3, or 4, or a CD4 less than 25%. And then for presumptive HIV infection in children under 18 months is that you start or you continue cotrimoxazole if they're already on it, regardless of the clinical staging or CD4 percentage. And then you only stop if HIV negative confirmed or if HIV infected when the CD4 is above 25% or WHO clinical stage 1. Then for children between the age of 5 and 10, with a history of PCP, you actually continue or start cotrimoxazole regardless of the CD4 percentage. Then if the child is less than 5 years, you only stop if the child is in WHO clinical stage 1 or CD4 above 25%. And if 5 to 10 years, you have to use the adult criteria, which we're going to talk about next. So other special population are pregnant women. So for pregnant women, you start as soon as possible, and then you are advised not to give Fancida, as the cotrimoxazole will be able to prevent malaria in pregnant women. Then for breastfeeding women, you have to continue the cotrimoxazole if the CD4 count is less than 350 mils, or if WHO clinical staging from stage 2 to 4. Then stopping in pregnant women, you actually have to continue throughout the whole pregnancy, and then you assess the woman postnatally according to the adult criteria, which we'll talk about shortly. And then for breastfeeding women, you only stop if the CD4 is above 350 cells per mil for 2 consecutive values, which are 6 months apart while the woman is on CrAg. Then for adolescents and adults, you start cotrimoxazole prophylaxis if the CD4 is less than 350 cells or WHO clinical staging 2, 3, or 4. And then you only discontinue the Septrin when the CD4 is above 350 cells per mil for 2 consecutive values 6 months apart while the individual is on CrAg. Then the other indication for stopping is when the person or the individual developed severe adverse effects such as Stevens-Johnson syndrome, severe liver disease, severe pancytopenia, severe allergy to sulfur drugs is also an indication to stop, severe renal disease, or 6-glucose phosphate deficiency. Next. Yeah, so we'll skip the poll question again. Now, when it comes to tuberculosis and HIV, we know that about 70% of HIV-infected people have got TB co-infection. And then all HIV-infected individuals should be screened for TB and placed on TB if found to have TB. HIV-infected individuals with TB should begin ATT via DOTS as per national guidelines. Then persons who screen negative for TB should be given tuberculosis isoniazid preventive therapy, abbreviated as TB-IPT. So we have to look at how we are doing as a country. So this was a study that was done early this year, and we found that of all the patients who are on ART, only about 52%, which is about half, were screened for TB. And then about 97.5% of those who were screened for TB did actually not have TB. So what this indicates is that all these 97.5 were supposed to be on cotrimoxazole preventive therapy. But if we look at the data, only 11% were initiated on isoniazid preventive therapy, which shows that we are not doing very well, despite screening about half of HIV-infected persons, and then out of almost 100%, only about 10% are we initiating on isoniazid prevention therapy. Now, out of those who were initiated on isoniazid preventive therapy, only about 23% actually completed this mandatory 6 months of prevention. So this shows that we are still not doing very well, and hence we cannot see the benefit of isoniazid preventive therapy if we do not increase the uptake of the prevention. So if we look at TB screening should be done at every service point delivery. So whatever contact that an HIV-infected individual makes with the facility, they should be screened for TB. So the screening for TB is actually very simple. We ask if the individual has got any current cough of any duration, if they're having any fever, or weight loss and night sweats. So any positive symptoms actually should prompt that you do some tests to screen for TB. So if the patient has got a positive screen to TB, from this, you actually investigate for TB. And we know from the guidelines that the gene expert is the recommended, then you can do other supportive like microbiology for AFP, microscopy, chest x-ray, and other modalities that are recommended. Now, if the patient is negative to the above screening, you immediately start the isoniazid prevention therapy. And here is how we initiate that. So who should receive the TB IPT regime? So HIV-infected children less than 12 months with a history of TB contact, and this could be in parents or other members of the household, the same household. Then HIV newly infected children above 12 months also should be started on TB IPT if they are negative to the screening. Then newly HIV infected pregnant and breastfeeding women, newly diagnosed adolescents and adults should also be started, and all children, okay, who after completing the full course of ATT, having been diagnosed of TB, should continue isoniazid preventive therapy for 6 months. Now, with a contraindication or exclusions or indication to stopping TB IPT is when, number one, a suspected or confirmed TB case. So there you do not give IPT, but instead you start full ATT treatment for TB. Then if the individual on IPT develops jaundice or has got active hepatitis, this can be pre or post the starting of the IPT. Then a person who is known or suspected to have isoniazid hypersensitivity, or develops a rash, a skin rash, while taking isoniazid preventive therapy, it should be an indication to stop. Another one is when an individual, while on TB-IPT, develops confusion, convulsions, or severe dizziness. That will also be an indication to stop. Peripheral neuropathy is also an indication to stop, especially if the patient was not receiving B6, as it will be discussed later. Then other drugs that we should consider not giving together with IPT is warfarin and epileptic drugs, selective serotonin reuptake inhibitors, antidepressants, and then ketoconazole and itraconazole, which has got drug-to-drug interaction with isoniazid. So the dosaging for the adults is 1 tablet, which is 300 milligrams OD, combined with pyridoxine. And then for children, of course, we give a formulation of 100 milligrams tablet, which is varied depending on the weight band of the child. Then the duration should be given 6 months. So cryptococcal infections are not really covered. The screening is not covered in the Zambian treatment guidelines, but what we should know is that cryptococcal meningitis is a serious opportunistic infection, which is one of the major causes of morbidity and mortality in people living with HIV. It accounts for about 15% of all AIDS-related deaths globally, and it is rare in children. So screening with CrAg prevents invasive cryptococcal infections, but we are not going to talk about that because they are not currently adopted in the Zambian guidelines. Sexually transmitted infections. So HIV-infected individuals should be screened for common STIs, which are syphilis, hepatitis B, and genital urethral discharge and ulcers. So the screening for syphilis. So the screening tool that we are using for syphilis is the RPR, and then the screening for hepatitis B is the hepatitis surface antigen, and then for STIs, other STIs, we are using a clinical approach or syndromic approach, which is any urethral discharge, any genital ulcer, any vaginal discharge, painful coitus, or postcoital bleeding. Then for treatment, of course, syphilis, it depends on the stage. So for early stage, there's a single dose of benzathine penicillin, and then early latent or unknown duration, you give 3 doses of benzathine penicillin, which are given weekly apart. Then late stage, it can be given up to 21 days, and mostly these patients will require admission. For hepatitis B, for HIV-infected individuals, of course, you start treatment with regardless of the CD4 count, and then you continue with TDF, even in patients who are failing first line and have to be taken to second line. Because of the presence of hepatitis B, you have to continue the TDF despite it having been in the first line for HIV. Remember that abrupt stopping of tenofovir in patients with hepatitis can actually lead to a rebound disease, or what we call a flare. Then, if there is renal insufficiency, you have to ensure that you consult expert opinion, of which most of us have got access to the 70-40 toll. Then for other STIs, we advise to follow the syndromic management of STIs, which are normally available in our facilities. So the take-home points from this presentation is that all HIV-infected individuals should be screened for TB, cryptococcal infections, and STIs at baseline and on every subsequent reviews, especially in high-risk patients. Then number 2 is that all HIV-infected individuals with CD4 less than 350 mils, 350 cells per mil should receive cotrimoxazole preventive therapy. Then 3, all newly HIV-infected individuals should receive TP isoniazid preventive therapy for at least 6 months. Thank you.
Thank you so much, Dr. Mpeta. One more time, we would like to apologize. Technology can be good, but also we can have some challenges. So we acknowledge that. I'm sure you can get us clearly, but you are not able to see the team at the hub. So we've had Dr. Mpeta just go through the preventive packages, and we've looked at cotrimoxazole preventive therapy, and he took us through the different populations. And we also looked at the preventive therapy and the screening algorithm. Then the other packages that we looked at was STI, some screening tools there. And he also talked about clinical approach in terms of screening. Now, I would like to encourage our folks there. We are able to see you. I'm acknowledging everyone that is participating. We have Chilenje, Livingstone, and we have Matero, Senanga, Choma, Nangongwe, and other individuals. But we had the question from Lewanika. So Lewanika, please, would like you to come through and contribute. And any other, please feel free to participate, ask questions and comments. Lewanika?
Hello, you can get us from Lewanika?
Yes, please.
Okay, so there's a question from one of our participants here. I'll allow them to give the question.
Okay, my name is Precious. My question is on the CPT for children. Why do we only give CPT or start to give it at 6 weeks? Why not give it starting from birth with the other prophylaxis medication?
Okay, thank you so much, Lewanika, for that question. Dr. Mpeta?
All right. I think the indication of giving an allowance of 6 weeks, I think it's just because of the side effects of the cotrimoxazole. Remember that the drugs that are, the individual drugs that are in cotrimoxazole actually have got a side effect on the bone marrow. They are antifolates. So it can actually give a side effect resulting in severe anemia and bone marrow suppression if we are to study it from birth, because we are trying to give chance for the bone marrow to develop and establish itself. And it's one of the reasons why we start at 6 weeks. If there are any pediatricians who would like to add in the house or anywhere, can please try to assist.
And the PCP is rare in less than 1 month of age. Can you repeat that?
Can you repeat that? Can you please speak a little bit louder and repeat that?
And
Dr. Thomas?
PCP is rare in less than 4 weeks old.
Okay, Dr. Thomas is saying PCP is rare in the younger children, less than how many
6
months?
weeks.
6 weeks old. So any other questions from our folks out there and all the participants' contributions and comments? Nangongwe, would you like to say something? Nangongwe Clinic. Oh.
Hello.
Hello, we're getting you.
Yes, my first question is on the presentation of the data that was presented. It came out that 70% of HIV have TB, or is it the other way around? So just want to seek that clarification. And also, as part of the preventive therapy, we now have PrEP. And my question was, is it rolled out now that we can out PrEP to those that are eligible? Thank you.
What's the second question?
Okay, thank you so much for those questions. The first question was on the data that was presented, and Dr. Mpeta will be addressing that. And then the second question was on PrEP, that we now have PrEP. Has it been rolled out? That is the second question.
Okay, yes. I think concerning it's supposed to be 70% of individuals with TB have got HIV. They are co-infected with HIV.
Okay. And then the second question was on PrEP. And now that we have PrEP, has it been rolled out in our country? We'll ask also any other people out there who would like to comment on PrEP. Dr. Mlenga, we can see you. Dr. Mlenga, would you like to comment on PrEP? I know you can't see us, but you can hear us. Can you hear us? And we can see you, Dr. Mlenga and Dr. Mwemba. We can see you, but I know you can't.
It's muted.
Yeah, I'm trying. But...
Hello.
Hello. Yes, we are saying we can see you, and I know you can't see us, but can you comment? There was a question on PrEP. That now that we have PrEP, and I think that is highlighted in our guidelines, has it been rolled out?
Yes, so PrEP has been rolled out the whole country. We are using TDF FTC, but there are certain places where we don't have the TDF FTC or the Truvada where we have the TDF 3TC. So it's available throughout the country. Then over there was the issue of the cotrimoxazole and less than 6 months, 6 weeks, as Dr. Mpeta said. In fact, the use of cotrimoxazole in less than 6 weeks is not just restricted to the prophylaxis. It's for even when you're using cotrimoxazole to treat any other condition. It's not indicated in that age group, and there's no even dosing recommendations for that.
Thank you so much, Dr. Mlenga. I think Dr. Mlenga has raised one other important issue, that cotrimoxazole is not only not recommended for children under 6 weeks for prophylaxis, but also even for treatment. So we have Lewanika. Lewanika still has their hand up. You'd like to ask your question? Okay, Chilenge have a text. Read out the question.
We know that according to the guideline, IPT should be given for 6 months, but a research published by WHO in 2011 shows that in high TB incidence and transmission settings, 36 months IPT has got a greater advantage compared to 6 months. Why are we still giving 6 months instead of 36 months?
Thank you for that question, Chilenge. And Dr. Mpeta?
Yeah, so if we see at the literature that actually has been published around isoniazid preventive therapy, there has been a lot of research done in this area. But actually, what you have said, that paper had actually shown that there's no difference when one receives for 6 months compared to one who receives for 12 months. And the reason is the difference was there, but it was quite minimal that it could not change the outcome. So the issues of side effects and also expense comes into play, and that's why Zambia settled for 6 months. So we know that it's quite effective for 6 months, especially for those who are in low endemicity, low TB endemicities, compared to those who are in high endemicities. But I think the difference in the statistics were not so significant that should mandate Zambia for us to move to 12 months.
Okay, Chilenge, I'm sure you've gotten that explanation from Dr. Mpeta. Are there any other comments from the spokes and people out there? Any comments before we move on to the next bit of our discussion this afternoon? And in the hub also, we are joined by quite a number of people. We have specialists from the ID unit and other members of staff. We have someone who would like to just ask a question. Please come through. So there's a question from the hub.
I'm Mary Chizuka. My question is on IPT. You said that after the TB treatment in children, we are supposed to put them on IPT. I just wanted to find out what are the benefits or the rationale behind this. Thank you.
So the question is, in the discussion or in the presentation by Dr. Mpeta, he did mention that after treatment in children, TB treatment, they're supposed to be on isoniazid prophylaxis at least for 6 months. So the question is, what's the rationale or what's the value?
Okay. So the benefits is actually just an extended protection. If we look at some of the children, I think they were more prone to TB relapses. So the extension of the TB IPT after completion of TB treatment is just, an extended benefit in terms of trying to prevent relapses or incomplete treatments. But otherwise, they are regarded as at baseline, so to say, when after they receive TB treatment, that is also considered like at baseline. So they will have an extended benefit in terms of prevention of relapses or reinfection.
Okay. So thank you so much, Dr. Mpeta, for that. We also have Lewanika. Lewanika have a question. Lewanika would like to contribute, or you have a question, please come through.
There's a question from Lewanika.
Please proceed.
My name is Lukonga, and my question goes on IPT. I've seen the eligibility of IPT. I just wanted to ask over the children who are HIV negative, that's less than 1 year, if they have a TB contact, are they not eligible for IPT?
Okay, Lewanika, thank you so much for that question. So if I may paraphrase your question one more time. You're talking about eligibility of children who are HIV negative and they have TB contact. Are they also eligible for IPT? Dr. Francis, would you like to comment?
Yes. So children who are exposed to especially sputum positive TB and are in direct contact with that index are supposed to be put on isoniazid preventive therapy for 6 months as well. So it is indicated even in those who are HIV negative.
Well done. That's we like the participation, and thank you for that question, and I hope you've got the response. If we can proceed now, if there are no any other comments from the presentation, would like to look at some case studies, and we encourage you to participate as we look at these case studies. We have quite a couple of questions in terms of what we are discussing this afternoon. We are looking at preventive packages. And our first case scenario, we have 2 cases. We have the first case scenario. So the first case scenario is quite wordy there, but please follow through so that we can internalize this and participate in the discussions. So we have Mapalo, a 3-year-old orphan. The mother died from HIV when she was 10 months old. And she was tested at 6 weeks and 6 months in terms of early infant diagnosis, and the results were negative. She's been living with an aunt in Kanyama and has been doing well until 3 weeks ago when she developed diarrhea, which is still continued. And then since then, Mapalo's weight hasn't been going, Mapalo's weight has been going down. You weighed her and found that she is very low weight for age, and that's about 10th percentile. And then on physical examination, she appears small for her age. She's a febrile, but she also has oral thrush. She has no obvious signs of dehydration and has no other concerning physical findings. You tested Mapalo on this day when she visited your clinic, and she's HIV positive. So I'll just give maybe a minute or so, maybe less than a minute, a few seconds, for teams out there just to, and here at the hub, please, everyone is free to participate. Just think through the case scenario, read through it, and try and understand it. Following this, we have a few questions for our discussion. Okay, so we'll proceed with our questions. So the first question from Mapalo's scenario, how would you approach this patient? That's the first question. Think through that question, and this proceeds with the next question. What screening tests would you perform? And we learned from Mapalo's scenario that when she came to the facility today, or a few weeks ago, she was found HIV positive. When would you start CAT? So these are the three questions, and we encourage everyone out there from the spokes and anyone participating this afternoon and from the hub to respond to these questions. Let's get back to the scenario, and I hope you can remember the questions. How would you approach this patient? Okay, anyone from our spokes? We'll start with our spokes. Anyone who would like to give it a go? How would you approach this patient? What would you do? Anybody? I'll pick on Chilenge. Chilenge, would you like to give it a try? Chilenge? Chilenge First Level Hospital. I hope you can remember the questions.
Yes, we get a question, but we got the scenario well.
Okay, we are getting you. You can proceed with your contribution. Hello, Chilenge, are you on? Okay, while Chilenge is still thinking, I'll pick on Lewanika. Lewanika, would you like to give it a go? We have our scenario there, and the questions, the first questions are, how would you approach this patient? And what screening tests would you perform? Then the other question is, when would you start CAT? Lewanika, are you with us? Lewanika, we are picking on you.
But nonetheless, I think the most important thing here, we want to stabilize the patient. Our approach will treat that patient first for malnutrition, and then our screening, I think, would want to do an MCS by the ZM stem to look out for OIs, especially cryptosporidium or isospora in this patient. And then later on, our approach starts treatment as soon as possible. I think 2 weeks will do until we deal with the diarrhea and also the nutritional status of the patient. So that's the attempt on behalf of Lewanika.
Thank you so much, Lewanika. Thank you for that contribution. So can we get back to Chilenge? Chilenge, are you ready for us? Would you like to say something? Would you like to contribute? Chilenge, are you ready? Okay. Okay. Okay, we seem to have a problem out there. We can't get Chilenge. Any other contributions, even from the hub? Anybody else that would like to contribute? Lewanika? Lewanika, you are back. Lewanika, you want to say something again? Please proceed. Lewanika?
Hello, you can get us?
Yes, we can get you.
Okay, yes. My name is Tilele. Hello, can you
Yes,
get me?
Chilele? Yes,
Yes.
Chilele, we can get you.
Tilele. That's the T.
Tilele. Oh, Tilele. Sorry for mispronouncing your name. Tilele, please proceed.
Okay, so my colleague had attempted the question. So I think one thing he left out on the approach of this patient is we have to take into consideration that this patient is an orphan. She's 3 years old, so we have to look at the social and psychological background as well. So we need to engage the social workers who will be coming to collect drugs for this child, who will be taking care of the child, as well as the psychological aspect of it in the approach to this patient.
Very valuable contribution. Are you still, sorry, did I cut you short?
No.
Okay, thank you so much for that contribution. Yes, you are right. This child is an orphan, and the social aspects of this child are very important in terms of when you are about to initiate CAD, you need to look around some of the issues that may affect adherence. So thank you so much for that contribution. I think we will proceed if there are no any other contributions. So we want to proceed with the discussion, and Dr. Mpeta will just take us through on this case study.
Yeah, so quickly, when you get a patient like this one in a clinic, we always have to remember that we have to assess the patient fully, and then we use what we call the SOP methodology in assessing this patient. So first of all, we have to look at the subjective signs. Then we look at the objective signs, then you put everything together and you make the plan. And I'm glad that a lot of people have actually suggested a number of things in the plan. So when we look at the subjective signs, we know that this child has got diarrhea and weight loss, which they have reported as the main symptoms for coming to the clinic. And then objectively, these are things that we have assessed. We found that this child has got malnutrition, which is in the 10th centile weight loss, oral thrush. So if we assess this patient, we find that the main problems are diarrhea, malnutrition, like it has already been said. And then let's not forget HIV, and this is actually WHO clinical stage 3. So in our plan, we have to look at the first assessment, which is diarrhea. We have to investigate the causes. And as somebody had said, we take the stool for analysis to look for GI opportunistic infections. And then management, of course, has to focus on assessing the hydration status. And when there is dehydration, you have to focus on rehydration, and then also giving of zinc sulfate. The malnutrition, of course, you have to initiate the protocol for managing malnutrition, of which most of us are braced to. And then the issue of the HIV, we know that this is clinical stage 3, and we learned from the didactic that at every point that an HIV-infected individual comes into our facilities, we have to screen for TB. So TB screening is very important by the algorithm that you are given. Then baseline sampling, which of course needed in HIV infection. There's the CD4 count, the hemoglobin, which is, we can either do just HP or full blood count, depending on what is available. Then creatinine, and then ALT and liver enzymes. Then if negative for TB, you start TB isoniazide preventive therapy. And this child is about 3 years, so you also have to start cotrimoxazole preventive therapy, and then you initiate CAT immediately. So if you find that the causes of the diarrhea is not anything of opportunistic in nature that will make you, have a lag in terms of 2 weeks, this child should be initiated on ART, on CAT. So whether you wait or not wait depends on your current assessment. As you know, this is a clinical scenario. We cannot interrogate further exactly how sick this child was in terms of can they take something orally or can they not. But by and large, going by the information that we have been given, this is a typical child that you can start ART at first contact.
Thank you so much, Dr. Mpeta. So that was a wrap up on our case study, and using the SOAP approach, I'm sure we've been able to learn from the contributions from the spokes and even at the hub, and also just wrapped up on what are the best practices. What would we do in terms of if you had a case like this one? And key issues here is you screen thoroughly, and also if you find that there's no active TB, I think we have already mentioned that you can put the child on preventive therapy. And the initiation of CAT is immediately, as soon as possible. So this is our first case scenario, and I hope that we picked quite a number of lessons from there. Then the second case scenario, we're moving on to our second case, and I'll just read through it and allow people to internalize, and then we have a discussion together. So we have a previously healthy male who is 35 years, and he's unmarried and a businessman, newly diagnosed HIV positive, and has come to your ART clinic, and he's ready to start therapy. During the enrollment and initial history taking, he informs you that he has had a productive cough for 1 week, for which he was given amoxil and erythromycin at a health center without improvement in the cough. He has now developed a fever and fatigue. He also had some blood tests done the previous week, and the results are CD4 is about 146 cells, hemoglobin 10.3, and CRS68. And on physical exam, you find that he's walking, and he's about 92% in terms of. And then the temperature is 38 degrees centigrade, and he has mild pallor, but has some cyanosis, has some crepitations in terms of lung auscultation, and then rest on physical exam was unremarkable. So I'll give you a few minutes to just think through, internalize this case scenario, and this will follow through some questions, similar questions to the previous scenario. Okay, so we'll proceed with our discussion, and we have the questions, and the questions are very, in fact, let me say the same with the previous scenario. So how would you approach this patient? What screening tests will you perform? And when would you start CAT? So we'd like to hear some contributions from our spokes out there. And anyone on the platform that is participating, we can see you all, except you can't see us. I've seen Dr. Mlenga and Dr. Mwemba there. We've seen you. And anybody else that would like to give it a go? We'll pick on a facility that did not participate in the previous discussion. I will volunteer Nangongwe. Would you like to give it a go? You can't see us, we know, but oh, you can see us now. Okay, sorry. Okay, so technology, now we are back. So would you like to contribute, anyone in the network? Nangongo, are you ready to contribute or ask questions? Contribute to the questions?
Yes.
So we are back. Yes.
Hello.
Thank you very much for the question.
Yes, the questions are there on the screen.
So the way I would like to approach a patient is, of course, is a productive cough. this patient will have to be investigated for tuberculosis and also CPC. And so with the fever, if the patient comes out positive for tuberculosis, we initiate ATT, that is before ART. And once the patient tolerates ATT, we straightforward start the patient on ART CAT. The results also from the blood test shows that the HB is on the lower side. Of course, we start the patient on hematinics, just improve on the hemoglobin count. And in addition to that, is a working man. Of course, though not married, would want to also try to elicit for other sexual contacts in the pre-testing, in the pre-initiation of ART, and depending on the results that comes out, do they need for that patient.
You are done, Nangongwe. Sorry, I didn't get your name in the beginning. Sorry for addressing you by the facility. But yes, are you still contributing?
No, for now. Thank you.
Okay, thank you so much. Thank you for that contribution from Nangongwe. So we have okay, so Livingston.
Mwanza, individual.
Oh, we have an individual who would like to participate. Mwanza, yes, we have Mwanza. Mwanza, would you like to say something, please? Proceed.
Yes, please. Yes, I'm sharing from Eastern Province. You're getting me?
Yes, we are getting you.
Yes, this is to me, it's a very straightforward case because one, this person is not married, and we have seen that the CD4 is very low, and already it's suggestive of pulmonary tuberculosis. So for me, the screening test for me would be to order sputum for AFB, just to rule out TB, and also to do a chest X-ray. And as my colleague have already put it, we can also do a syphilis test. And since this person is not married, we also needed to also investigate his sexual history. And after those investigations are done, I think he has to be immediately commenced on CAT. Thanks.
Thank you so much, Mwanza, for those valuable contributions. Thank you so much. And we have Lewanika. Lewanika also, they would like to contribute. Lewanika, please proceed. Yes, you can proceed.
Yes, just a comment and also a question. The comment on the hematinics, I don't think it would be necessary to start hematinics in this patient who seems to be having an active infection. So maybe creating a breathing site for bacterial infection. So I think hematinics will really put a hold on them. And then the other concern, I think I've heard Livingston saying it's an easy case. But I think it can be difficult in a place like Newanika here, where logistics are be difficult for patients who are coming from very far. Because if you have to order sputum and do a chest X, that will take you almost like 2 weeks to start to confirm that the patient has TB. So is there for us to start medication ATT immediately without waiting for the results based on the history and our physical findings? Thank you.
Well, those are very, very good questions, and I think the discussion is quite healthy, and we can tell that people are listening. So we would ask there's still somebody else with another question before Dr. Mpeta comes in to respond to some of those concerns. We're sharing best practices and also learning from one another. So there's a question from the hub.
It's not a question, actually, it's a contribution. This is Dr. Achambwa. It does sound simple, but I guess it could be a bit complicated. I think the first contribution mentioned most of the things that are needed, but I just want to point out that there was mention of cyanosis in the case scenario. Even though the sputum is productive, that should still make us think of other pulmonary infections in patients with AIDS, such as pneumocystis, Eurovechi pneumonia. So I know in most places it will probably be difficult to confirm the diagnosis because it may not be possible to do stains for PCP, but that's another diagnosis we ought to keep in mind because of the cyanosis as mentioned. You could also walk the patient a little more and see if they desaturate, but I agree that this history is consistent with tuberculosis, either MTB or even non-tuberculous mycobacteria. So in places where they have gene expert, that would be one useful test to do. If a gene expert is negative and there's still AFB that's seen, one would think of non-tuberculous mycobacteria such as MAC.
Thank you so much. Those are very valuable contributions. If we don't have any other contributions or questions, we'll proceed now to just summing up the discussion.
Sorry, I don't think we addressed his question about whether we can treat this patient presumptively in a place where they don't have gene expert or chest X-ray.
So can answer it, Dr.
Okay, I thought Dr. Chamba actually was going to make a comment.
So yes, you can go ahead and treat the patient presumptively. I think, so that's it makes sense. This story is consistent with TB.
So I think we are familiar with the questions. Is we are looking at the approach, the screening, and whether you would start CAT or not. Now, if we look at today's topic, it's basically looking at the screening and the preventive modalities that are there in the HIV. So the second scenario, the real big question is we agree that this patient is has got signs and symptoms of TB, and would actually say that the TB screen is actually positive. So the big question that we have to answer: is this patient supposed to be on TB isoniazide preventive therapy, or is this patient supposed to be on ATT? Of course, we know that this is one of the indications that you cannot give isoniazide preventive therapy because the patient has tested positive to the TB screen. So if we remember the algorithm, this is a patient that you go ahead and investigate for TB. Of course, the recommended first line is the gene expert, and we know, like we have been told in a number of spokes, that this is not easily, it's not something that is easily, which comes by in the spokes because of, some of the centers are quite isolated and all that. So looking at this patient and seeing how positive the screening test is, and as Dr. Chamba has said, you can presumptively treat for TB. Now, in centers where we are able to do, gene experts and other tests, we have to ensure that we do this test and confirm or rule out TB, because that is in tandem with best, clinical practices. So if we follow the same approach, the SOAP approach, we know that subjectively, this patient came in with symptoms of a cough that did not respond to first-line antibiotics, and then there was fever and fatigue. Then objectively, we found that the temperature was raised to 38 degrees Celsius. The patient was pale at crepitations and a low CD4 count. And then in our assessment, I think, sorry that we did not include the desaturation, the cyanosis, because I think my slides here was said, but no cyanosis. So I think, when sending there was a bit of alteration. So this patient will go by that did not have cyanosis. Then the assessment, of course, this is a patient with cough and fever, which are positive, TB screen symptoms. And then we understand that this is a businessman and which puts them at STI risk, high risk actually, and then the patient also ultimately has HIV with severe immunosuppression, a CD4 of 146. So the plan, like it has been discussed by other, earlier speakers, is when you test positive for a TB screen, it should prompt you to now do further tests to rule out TB. The GeneXpert, the chest X-ray, and AFP microscopy. So if positive, all right, you have to start, the TB treatment. If negative still, depending on your assessment as the attending clinician, you can still presumptively treat for TB unless you have done other tests to prove otherwise. This patient, again, is at high risk of STIs, so we have to screen for, genital ulcer disease and urethral discharge in this patient. Other tests that we have to do is RPR and hepatitis surface antigen, which are very important, screening tools in high-risk patients. Lastly, which is HIV with severe immunosuppression. The bloods at baseline, of course, should have full blood count, creatinine, and liver enzymes. Then in terms of drugs for prevention, Septrin, TB, IPT should not be given in this patient because they have tested positive for TB screen. So that is one of the things we should take care to note, that when a patient tests positive to TB screen, please don't start the TB isoniazid preventive therapy because they are potential candidates for ATT. All right, then you initiate CAT as soon as the patient can tolerate because of the severe immunosuppression. That is if you start treating for ATT.
Thank you so much, Dr. Mpeta. We are almost winding up with our discussion this afternoon. And if there are any other comments and any other contributions, we have Chilenje. Chilenje, they would like, if you have a question or contribution, please proceed. Okay, it's a chat. There's a question.
Can IPT be given to a TB HIV co-infected patient who has just completed the TB treatment, but the CD4 count is still low?
So we heard from the didactic that continuation of isoniazid preventive therapy is indicated in children who have completed TB. In adults, there have been no studies to show the benefit of such extended prophylaxis. I don't know if there's anybody who would want to add to Dr. Chambo. Continuation of IPT in a patient who has been declared cured in adults?
Yeah, currently the guidelines do not recommend that. I think the IPT guidelines should be published soon. They're just being revised, so the recommendation is not to.
Okay. So thank you, Dr. Chambwe. Do we have anybody else that would like to contribute or question or comments? Yes, Dr. Mwemba.
Yes, so I just wanted to make a comment on the question. I'm sure it was Chilenje. No, actually it was from Lewanika, because Lewanika wanted to find out about the patient whether presumptive treatment should be given or should not be given. So my concern was that actually that Lewanika General Hospital is a big hospital. And if Lewanika General Hospital is just doing an X-ray and doing sputum or GeneXpert can take 2 weeks, then imagine how many of these patients will just be starting without actually diagnosing them. And I think that so we need to find out exactly why these centers don't have a result within the shortest possible period of time to make a diagnosis.
Okay, so Lewanika, I hope you've gotten that comment from Dr. Mwemba. I think the concern here is that why should we proceed with a presumptive treatment for TB for a hospital like Lewanika, and why should it take this long? So where possible, we'd like to have a diagnosis that is verified for these patients to start treatment. So that is the concern from Dr. Mwemba. So Lewanika, again, would like to say something.
Go ahead.
Go ahead, Lewanika.
Lewanika here.
Yes.
Yes, we appreciate the comment from Dr. Mwemba. But the question was basically to put in perspective of other centers which are very far from Lewanika Hospital. Definitely, someone in Lewanika would want to have given the result within 48 to 72 hours. But that question was, I think, trying to also look at other centers which are very far from Lewanika Hospital. But we do appreciate your concern.
Okay, so with that, I see Dr. Mlenga would like to say something. What's your comment, Dr. Mlenga?
Yeah, so I think one other thing which this platform is supposed to raise is the awareness of the services which are available around the country. And that's also part of mentorship, like systems strengthening and knowing where we have issues with certain systems. As Dr. Mwemba said, again, presumptive treatment, we don't encourage it, please. We have a lot of, we have zonal allocation of areas where you can do the gene expert at least. That should go ahead and try to have a bacteriological diagnosis. If you can, if you cannot, also try to make a radiological diagnosis as evidence for you to treat. It should be in a very difficult circumstance with consultation with an expert for you to go ahead empirically and just treat for TB without doing any investigations. I'll circulate the guidelines maybe later on this evening for the TB because for the IPT, we've seen an interest in this area so that people can familiarize themselves, especially the pediatric populations, HIV negative and HIV positive, and also the adult population.
Okay, so thank you so much, Dr. Mlenga, for that contribution. And I'm sure we'll go a long way to disseminate those guidelines. We have a hand here at the hub, and we also have a question from one of the facilities. So, Dr. Boyd, you want to say something?
Yes, there was a question I had because there was a discussion we had last week around pediatric TB. And I'm just wondering if you can help us just narrow down in which situations presumptive TB treatment is acceptable. Because last week there was, we had a long discussion around whether a particular, the case should have actually been put on presumptive TB therapy. So is that consideration only in pediatrics, or we just need some guidance? We just want to make sure people go out with the correct message.
Okay, thank you so much, Dr. Boyd. I think this is back to you, Dr. Mlenga.
Yeah. So, I mean, the main reason, even for pediatrics, why we have to do the presumptive treatment is the issues which are difficult with getting the right specimen for you to make the diagnosis. For adults, the issues of specimen collection and having the right specimen is not much of an issue. So what we are saying is, as far much as possible, both in pediatrics and also in the adult population, you need to have evidence of the TB. But we realize that there are certain times when you may not have such evidence. And if you have strong evidence that this is leading to, this is likely to be TB, then that can go ahead. The message is, let's try and have a diagnosis, principally bacteriological diagnosis. If we cannot have a bacteriological diagnosis, radiological diagnosis, and where you cannot have any of this, then that's when you go ahead with the third option.
Okay, thank you so much, Dr. Mlenga, for that clarification. And we have Choma. Is it a chat? No, we have Choma. Choma would like to ask. Choma, please proceed with your contribution or question. Choma. Choma.
Are you getting me?
Yes, we are getting you very clear.
Okay, thanks a lot. This is Edgar from Choma. Yeah, my concern was we have been told that the patient is single, but we have not been told anything about the family where the patient is coming from. So I'm concerned with the contacts. Maybe we could have maybe children who are HIV positive eligible maybe for also TB IPT. So I don't know, the doctor maybe can comment on that so that maybe we can also screen the family and ensure that those who are due for IPT, they are also given IPT in good time. Thank you.
Okay, thank you, Edgar.
All right, thank you very much, Edgar, for that concern. You were told, this is a case study, so further interrogation was probably limited, but in a real life situation, definitely that man is not coming from the bush, even though he's a businessman. So issues of index, testing comes in, of which we know that this is according to the Zambian guidelines and its protocol, that if one tests HIV positive, then we have to go and test the entire household. And even issues of positive TB screening, and when it comes sputum positive, automatically the children have to be on isoniazid, preventive therapy. And if not, the whole entire household where it's coming from has to be, screened for TB and other opportunistic infections if they are HIV positive. So you are definitely right. That has to be done when you get a patient who is coming. So let's not assume that somebody who is single, then it means that they are living alone. We should always interrogate the household where they are coming from and which sort of people they are sharing, the house with, so that we do index testing. We test the entire household and screen them for TB as well.
Okay, so thank you so much for all those contributions. I think we are almost coming to the end of our discussions, but we have one more question that has come through, and I think this will be our last question. And this question has come through a chat, and we'll read it and then respond. So the question is, in a patient,
so in a patient with a positive gene expert, but was exposed to isoniazid preventive therapy in the past year, what's the way forward with regards to the ATT? Is that the question? Dr. Chamba, would you like to contribute?
For that patient, to the gene expert, there should be information on the rifampicin resistance or susceptibility. I would say go ahead and treat with a regular treatment for TB, but do a culture for DST.
Okay. Thank you so much for that contribution. I think with that last question, we will be summing up and concluding, and I would like to say thank you so much for everyone's contribution, participation. I think this has been an educative discussion. We were looking at preventive packages, and we looked at cotrimoxazole preventive therapy, and then we also looked at isoniazid preventive therapy and the screening algorithm, and we also did touch on STIs and just a little bit on CrAg. So I hope that we have gone out with something, and thank you so much everyone for your participation. We are having our next session, I think next week, same time, and this is a build on. Next week we'll be looking at care of an HIV exposed infant. So thank you so much for everyone's participation. And please, we are having a little bit of challenges. We'd like to encourage all of us that are participating to actually submit your attendance registers. We need those. And yeah. And if you can submit them immediately after this session, we'll really appreciate. Otherwise, thank you everyone and all the experts and participants that contributed to this discussion. We really appreciate it. And thank you so much, Dr. Mpeta. So see everyone again next Monday, same time.